Good morning. Welcome, everyone, to the Investing in Referral Networks to Advance Racial Health Equity webinar series. This is part one, centering community experiences in resource referral systems. My name is Artrice Morrison. I am the Interim Executive Director of the Western Region for Health Leads, and I'm so excited for you to be part of a conversation of this information that we've gathered with community to share about community referral networks. Before we begin our conversation today, there are a few housekeeping items we'd like to review. Today's webinar will be recorded. I know that is the hot question that happens often. Yes, we will be recording this session, and then it will be available to all those who've registered, and then we will also place it on our website for those who you want to share it with who did not register. During today's webinar, we'll have time to answer some questions, as many questions as possible. Please submit all of your questions using the Zoom Q&A button found at the bottom of your screen. You can also use the Zoom chat feature to share comments, reactions, and the links your fellow attendees and panelists. This webinar also has closed captioning available. To enable closed captioning, please click the closed captioning icon on the bottom of your Zoom screen. Last but not least, at the end of the webinar, we'll be launching a poll and evaluation survey. So please take some time to quickly share your feedback on today's webinar series. I don't want to be remiss about interpretation. If you'd like Spanish interpretation, please click the globe at the bottom of the screen and it will connect you with our translator. Thank you very much for that. Next slide. We'll start our webinar today by hearing findings for the RePARE work from two of our Health Leads colleagues and program managers, Daniel Chow and Christina Zuniga. And then we'll be putting their information in the chat. And then today we'll also be hearing from two members of our community advisory group whose bios will be available in the chat as well. Gary Bliss, Director of Medicaid Accountable Entity and ACO, serving more than 22,000 members of the Prospect Health Services in Rhode Island. And Nubia Padilla, the Accessibility and Inclusivity Manager of Sonoma County Regional Parks. We're so excited to have them here as part of our conversation today. Next slide. As we begin this conversation, we're going to begin it like we start most of our meetings at Health Leads, with our practice agreements and our racial health equity principles, and sharing those with you today. I'll read them just so that everyone has an opportunity to kind of take it in terms of how we're going to come together and be in spaces together today. Our practice agreements are: address racially biased systems and norms. Recognize power dynamics in the room. Be intentional about how you exercise your privilege. Remember, we all have bias. Biases are learned and can be unlearned. Practice the ability to recognize personal biases, emotions, and triggers, considering how might they impact your actions. Be brave, be inclusive. Acknowledge the risks speakers take and value the privilege to learn from one another. Individual values, cultures, religious beliefs, disabilities, sexual orientation, gender identity, and personal experiences matter. Conflict is always possible, and conflict is okay. Be open to anti-racist dialogue. Remember, Black, Brown, Asian American, Pacific Islander, and Indigenous peoples' experiences with racism are vast and varied. Avoid becoming defensive when Black, Brown, Asian American, Pacific Islander, or Indigenous people speak from lived experiences with racism. Be present, be accountable. Listen, feel no pressure to speak, yet resist the temptation to only witness the dialogue. Take space, make space. Call attention to unheard voices of people, ensuring that all individuals have space to participate fully. So I'll give a moment to think about these practice agreements. If there's something that sticks out for you, resonates with you, feel free to put it in the chat. Our racial equity guiding principles with the work that we do. With us, not for us. We will ensure that solutions are co-created, grounded in, and emerge from the experience from the most marginalized of our community. We commit to engage community and leaders of color who are working in and accountable to communities most harshly impacted by the issue. Fix systems, not people. We commit to understand and communicate that policies and institutions are the root of the inequities in our systems or services, and not the people navigating the systems. Commit to collecting both quantitative and qualitative data about race, ethnicity, gender, etc., and use it to recognize and support the greatest needs. We commit to collecting data that will help us understand who is at most negatively impacted and why. We commit to sharing the collected data with communities from which it came. And self-awareness and self-correcting behavior. We commit to self-awareness and the ability to recognize our own biases, emotions, and triggers. We commit to considering how they might impact our choices and decisions. Please feel free to take a moment and see if any of those resonate with you as well. Next slide. So as we begin our time together, we wanted to have a centering question. Can you think of a time when a community referral network significantly benefited you or someone you know? Was this process easy, understandable, and were you or their needs met? Please put your answers in the chat. Okay, and we'll hopefully have an opportunity to pull up on those answers and have voiceover it later on in our conversation today. But let's begin. Next slide. So again, I'd like to welcome my colleagues, Daniel Chow and Christina Zuniga, as they share the RePARE findings. We're going to walk you through our process, who we are, how this began, and then Christina will talk about the community impact findings that we have. Next slide. Health Leads, who we are. We're a nonprofit organization working locally and nationally to remove deep-rooted systemic barriers to health, center power resources within communities, and build a world where racial health equity is standard. Our vision is health, well-being, and dignity for every person in every community. Our mission: we partner with communities and health systems to address systemic causes of inequity and disease. We do this by removing barriers to keep people from identifying, accessing, and choosing the resources everyone needs to be healthy. Thank you. Next slide. Again, welcome everyone to today's webinar, and where we'll explore the critical intersection of health equity and the access to essential resources. Our conversation today navigates through the pressing challenges millions face in accessing food, housing, and transportation, essential components that shape our health and well-being. The pandemic has sharpened our focus on these disparities, revealing significant gaps in our societal fabric. It underscored the critical need for robust and private and public partnerships and innovative solutions to bridge these gaps. As we discuss, we'll delve into the role of community referral networks and their pivotal function in connecting individuals with essential resources through joint efforts among healthcare and social services. We stand at a crossroads with opportunity to rethink and remodel our approach to health equity. However, the path forward demands more than just surface-level solutions. It requires a deep collaborative effort to address and dismantle the structural racial and economic inequities that persist. We're excited for you to join us in our two-part series as we unpack community referral network model and explore how community voice, data, flexible funding, and backbone agencies play a crucial role in sculpting a healthier, more equitable future together. We can envision it and work towards a world where access to essential resources is not a privilege, but a right shared by all. Next slide. So through this project, the research to pursue and advance racial health equity, RePARE, we will begin to understand how the sector can design, implement, and sustainably support community-anchored referral networks in order to advance community health and racial health equity. Next slide. As important as to what we do, it's how we do it. We grounded our work in the CIE data framework, which is also colloquially called the anti-racism framework. Also, We All Count data equity framework, the National Equity Project's liberatory design practices. By rooting our project with these design equity practices, we sought to interrupt inequity, increase opportunity to engage the least resourced, and shift power to those the network seeks to serve. Next slide. The participating agencies that have and stakeholders in our work, we wanted to really lift them up and acknowledge them. The participating network organizations, the PNOs, they were here to help us identify community advisory group members, create access to their networks and community members via focus groups, interviews, surveys, and they help provide voiceover on equity challenges in our methods. The Community Advisory Group, the CAG, he'll be referred to here, was to identify questions we want to ask community members, identify equity challenges, provide their information and expertise and experiences for the data. The CAG also helped engagement in gathering data and distributing the research tools. And the role of their investor advocates was to provide input on the financial research inquiries, engage in stakeholder mapping activity to identify stakeholders within and outside of their agencies, and leverage their positional privilege and power to help RePARE research reach and influence their peers. And so we thank all of those folks who are engaged in this process with us. Next slide. And we want to thank all the community members who shared their information with us. We used a number of methodologies for collection of information. We conducted surveys to organizations, their network partners, community members. We also conducted a few focus groups and interviews. And now I would like to introduce my colleague, Christina Zuniga, to share the community member findings. Thank you very much.
Hey everyone, thank you, Artrice, for that lovely introduction. If we can move on to the next slide, please. So now we're going to go over some of the results of our community-informed research project. A few things I want to highlight. This was truly an intentional, collaborative process of centering community voices to listen and learn how various racial, ethnic, and multi-identity groups experience community referral networks across the country. We want to ensure that we do not lump all BIPOC experiences into one whole, as this may perpetuate racial health inequities for certain groups. And also we want to share that this information is coming directly from the community member perspective. And so one of the questions we asked is, how would you rate the resource referrals in terms of meeting their needs effectively? The study found that 64% of people find referral services useful. As a result, referral networks seem to be meeting the needs of clients effectively. Nearly 36% do not feel fully satisfied with these services, which is significant. Out of the 36 who do not feel fully satisfied with services they received, 22% of individuals do not meet their needs on occasion, while the referrals received by 14% consistently do not meet their needs. While these services are generally effective, a substantial segment of the population remains underserved despite their overall effectiveness. It is important to note the advisory group discussed the limitations of the survey to distinguish addressing diverse needs, such as the significant contrast between meeting food insecurity at a pantry versus meeting the housing needs of the unsheltered. The community advisory group has been motivated to explore and understand the diverse needs within their individual communities. A total of 53 respondents across all ethnicities believe their needs are fully met by the resource referrals they receive. The Latino, Latina, Hispanic community, which has the highest number and shows a wide range of satisfaction, showing that nearly 2/3 indicated that their needs are fully or mostly met. However, there is a substantial amount that does not. The white community shows a relatively balanced distribution of satisfaction, with slightly more leaning towards their needs being met to some degree. The indigenous and multiracial groups have a wide spread of satisfaction. Next slide. We also asked the question of how do organizations welcome the multiple identities you bring, such as race, sexual orientation. 46% of respondents said organizations handled their diverse identities very well, indicating that almost half felt their identities were recognized. Another 24% felt their identities were recognized well, suggesting a significant portion had a positive experience. The handling of identities were rated as average by 25%, indicating that there is room for improvement. Smaller segments, each composing 3%, were less satisfied with the recognition of their diverse identities, suggesting a minority were under-recognized. The wide range of responses between Latino and Latina, Hispanic, African American, Black communities suggests a diversity of experiences within these groups, and a variety of satisfaction levels might be reflected in this. The broad spectrum of experiences of indigenous and multiracial groups indicate different levels of recognition and satisfaction, emphasizing the importance of addressing diverse identities effectively. A total of 82 people across the identities listed believe their identities were welcomed. And the Latino, Latina, Hispanic community, which has the highest number of surveyed people, showed a wide range of feeling welcomed, as the African American and Black community. The indigenous and multiracial groups have a wide spread of experiences. So we also want to delve into a bit of the qualitative data here. 70% of community members said they had a positive interpersonal experience. Community members shared the importance of organizations creating a culture of values and respect, where organizations embraced diversity by showing representation of multiple identities, where community members are treated fairly no matter the circumstance, and where there is an acknowledgement of diversity, inclusivity, and representation. Next slide. 30% of community members said they had a negative interpersonal experience. Community members named facing discrimination and prejudice, sometimes naming being treated badly for being of a certain culture. Language barriers, the organization not having staff or interpreters for the community members' desired language, feeling unwelcomed, and cultural ignorance. Lack of understanding of other cultures. We also wanted to know about the barriers for community members for accessing services from organizations. Please note these are not ranked, rather they are resounding themes that surfaced from the findings. Multiple community members mentioned transportation challenges, difficulty in finding resources or understanding available services to them. There are concerns about income, affordability, and funding. Organizations may not have resources available. There's also mistrust or unfamiliarity with the organizations, fear of not being eligible, negative experiences with staff, racial profiling, and lack of professionalism. There's also concerns about insurance, citizenship status, and specific group assistance. We also asked, what, if any, changes would they like to see resource providers, organizations make to improve their experiences? Individuals' multiple identities resulted in a mix of experiences when interacting with organizations. Despite feeling welcome and respected, there were also instances of discrimination and prejudice, language barriers among respondents. As a result of the data, organizations must be culturally competent, inclusive, and sensitive to the diversity of individuals' backgrounds and identities. And so that was a bit of a snippet of information we're sharing directly from community members' perspective. And I'm now going to pass it over to Daniel, as he's going to go over the P&Os and network partner results. Thank you.
Thanks so much, Christina, for leading that with us. Hi, everyone. It's a pleasure to be here with you all today. Really excited to continue to dive in. And so, following what we heard from community members, we are now going to be diving into results and things that we've learned from the P&Os who we had the pleasure of working with for the past 18 months. And these are the 7 P&Os that Artrice mentioned earlier in the presentation. So we'll go ahead and dive right in. Next slide, please. So we are starting off with a few challenges that we've heard from our P&Os. A couple of the themes that we've heard when we asked this question that you all see on the screen here, list the ways that your organizations have been challenged when connecting clients to services in their resource referral networks. Two of the biggest themes that we found were system and infrastructure investment, and also investment into staff and skill building. So to talk a little bit about the first one, we learned that there was a really big challenge with investment from cross-sector stakeholders into local community-based organizations. Our P&Os felt that investment was necessary to support the needs of the community when they're trying to access these referral networks and resources in the community. Aside from fiscal investment, there was also a need for investment into staff and skill building as well. So really emphasizing a need for a culturally responsive workforce, and investment into skill building for their staff, particularly for working with folks with lived experience. Another dimension of staff was staff capacity and resource availability. That was something that was also highlighted, and I think is really highlighted when you see that quote on the bottom of the screen. Often the need of the caller is greater than resources that are available in the community. So those are a few key challenges that our P&Os have shared. Next slide, please. Along with challenges to connecting community members to services, there have also been challenges around advancing racial equity within their organizations. Just following up from that discussion around investment, again, it's not just fiscal investment, but investment of time. Um, as you all will see on the screen, a few things are funding and investment into building relationships and engagement and education takes time to truly be engaged with community members. And so we've um, learned that investment of time is crucial to fostering cultural humility, responsiveness to the needs of our community members, investment into building out these relationships, enhance community health, enhance racial equity by continuing to build trust rather than breaking that trust and creating further harm. Um, as you all can see from a quote by a piano at the bottom of the screen, as well, there are a lot of departments that are operating in ways that just aren't efficient or sustainable, which in turn can really create a lot of barriers to access for the community members that they're trying to help. Um, a really big particular area of challenge that was shared was that rural areas can be particularly challenging, um, having really large, diverse populations who need really specialized support, especially for immigrant and non-English speaking populations. So those are just a few other challenges that our PNOs have been uplifting. Next slide, please. And along with challenges, we are also seeing a lot of successes in this work also. Um, Even though those challenges exist, PNOs have been able to see success with connecting community members to services. Um, as mentioned by Christina earlier, around 70% of community members surveyed expressed that their needs were being sufficiently met. So there are successes along with the challenges as well. A few key tenets of this success are two that you can see on the screen, two main themes that we've found. The first is relationship and trust, and the second is feedback and a communication. And I think this ties in with what's been shared earlier around the importance of continuing to focus on building relationships with community members and really meeting folks where they're at. This is key to understanding which services are most beneficial for them, the best ways that community members are able to access these resources. And a few examples of what PNOs are currently doing at their organizations that are really working are warm handoffs and building strong relationships with service providers within their networks to ensure that services are both accessible and appropriate for the community members that they are referring to. Next slide, please. And so along with those successes, here are a few current initiatives that we're hearing from our PNOs on what's really been working for them and what they're excited to do in the future. So the PNOs recognize that there was a lack of community member presence and engagement and saw a need for folks to be involved in decisions that directly affect them. To address this, they're doing a couple of different things. So community recruitment for service-based positions. So making sure that folks are actually being supported by people who come from their communities and people who represent them. I think, again, drawing to the theme of building relationships with community members, there's no better way to do that than to actually have staff members who come from the community that they serve. There are a couple of other things that our PNOs are doing too that they find have been really helpful, creating different groups and committees for both staff members and community members to be a part of. So a few examples are Health Equity Council, a Social Determinants of Health Committee, along with developing clear collective impact statements with clear understanding of roles. for all stakeholders involved. So a lot of great success that is happening along with the challenges that we're seeing too. Next slide, please. And now we're going to be moving on to results that we've seen from our network partners. So we had the opportunity to survey our P&O members, as you all just saw, but we also had an opportunity to survey network partners of our P&Os as well. And so these can be organizations that are community-based, that are faith-based, these can be government agencies. So these results are coming from all those different perspectives. Next slide, please. So again, starting off with challenges that our network partners are sharing. As you all will see, there are similar themes across network partners and P&Os. The first on the screen being, again, limited funding and resource limitations. So there needs to be more funding and investment into programs and services such as community-based organizations. There also needs to be an investment into their staffing and operations. So again, having an adequate amount of staff, which will support their staff bandwidth and capacity, which in turn can help community members get connected to resources. And when we're thinking about operations, there's a lack of interoperability with the technology that our network partners are using. This leads to issues with inefficiency and miscommunication. So that's another space where funding would be really beneficial. Network partners also shared about client access to resources. A really big theme that we saw in our learnings were transportation, which is a major obstacle that clients face when trying to access resources. This is both in location of services and hours of services that really just don't align with the availability of community members. And another kind of barrier to access is the quality of services provided as well. There are challenges around referrals falling through in between service providers or different resources. The options for access are just very limited or simply don't exist to support the client. When we're thinking about things like challenges with language and accessibility, those are just a few examples of holes where community members might fall through. And last but not least, there was a challenge that we learned around trust between stakeholders. So from partner to partner within these networks, there was a lack of follow through or delay from providers, things like no return calls or incorrect or incomplete referrals. And so as a result, this can create really, really big challenges for community members to access what they really need to be healthy. Next slide, please. And similar to our P&Os, there are racial equity challenges that our network partners are seeing. Two big themes that you all are seeing on the screen are power dynamics and lack of data and information. So when we are talking about power dynamics, it was shared that sometimes there is an imbalance of power and influence between stakeholders, such as funders and organizational leadership. Network partners identified a lack of diversity on board of directors and leadership team members as a really big challenge, and that sometimes leaders don't prioritize racial equity initiatives. There's also a lack of data and information about community members to really inform what improvements and changes need to be made in order for it to be easier for folks to get connected to their services. Yeah, and as you can see the quote on the screen, the largest challenges were combating misinformation and the lack of trust in the healthcare system. Next slide, please. And again, although there are challenges that were shared, there are also really big areas of success that our network partners are seeing as well. The first one being relationship building. And so our network partners have expressed the importance of creating a personal connection with clients, meeting them where they're at, and continuing to do that as an essential part of providing quality service to the community. They're also providing specialized support. So we are talking about things like legal aid, language support, care coordination. Those are all ways that network organizations have provided specialized support to community members. And also really utilizing referral systems. So a few examples of this are 211 services and warm handoff referrals, referring clients from their orgs referring clients to organizations that they really trust and know that the client will be able to receive services from. Next slide, please. And again, similar to our P&Os, here are a few current initiatives that our network partners are seeing have been really effective in supporting their work. So implementing racial equity practices. These include anti-racist frameworks, guiding principles similar to the ones that Artrice took us through at the start of this call. Hiring a workforce of staff that reflects the demographics of the community that they're serving. So having a community-based workforce has been really effective, and training initiatives. So training staff members by certain departments, such as human resource trainings and different events, and including initiatives by diversity officers and different programs within their organization. Next slide, please. And so I know this was a lot of information, but as we think about what's been shared by Christina and myself, and what we've learned from our community members, P&Os, and network partners, these are 4 overall recommendations that we've collected to continue to improve our services to community members. So the first is centering on community voice. Second is accessibility to community resources. Third is community trust and relationship building. And last but not least, continued integration of racial equity practices. And really a big theme across all of these recommendations are all about connecting and building relationships with community members, making sure their voice is heard, and providing services that really truly connect them to what they need to be healthy. So that's a quick little snippet of what we've been hearing from our network partners and P&Os. And I'm really excited to move us along in this session today, because we have a few of those folks with us here today, which I am now going to pass over to Artrice to introduce.
Thank you, Daniel and Christina. Really appreciate that information. And again, everyone, this is just a snippet of a report that will be published in the next few weeks that we'll have access to reading the full report. But these webinars are just, giving you some taste of what we've experienced and what we've gathered. And with that, I would love to invite our 2 community advisory group members, Gary Bliss and Nubia Badia, to share their experiences as key contributors to our RePARE project. So we're going to take the slide off the screen. So I think we could see Nubia and Gary directly. And so perfect. So with that, I have some questions for you guys. So Nubia and Gary, will you please introduce yourselves and your organizations and what repair agency you represent? Nubia, you're on mute.
Good morning, everyone. Thank you, Chris, for inviting us here. My name is Nubia Padilla. I am part of the leadership board for Sonoma Connect Sonoma Unidos, and my day job is as accessibility and inclusivity manager at Sonoma County Regional Parks.
Great.
Gary.
Thank you. My name is Gary Bliss. I'm the director of Prospect Health Services Medicaid Accountable Entity, which takes care of about 22,000 Rhode Islanders who are on Medicaid. We're responsible for their health outcomes, total cost of care, and addressing their health-related social needs.
Thank you, Gary and Nubia, for being with us today. And so, how do you think the diversity of the group, of our repair group that we brought together, has influenced the process and the project?
So I think it had a great influence, and I think it speaks to one of the most important lessons of this whole project. And that is going back to one of the points from one of the very first slides you shared. Think about systems and fix systems, not people. You can't fix something that is broken, but was created that way on purpose by a system if your system looks like what created the inequity in the first place. You need to open it up, change it, listen, and include those folks who have not been well served by what has been created, or else you are going to just perpetuate and you will not correct what it is that we actually all want to correct and change.
Thank you, Gary.
I think diversity is very important in this research. By having different voices, backgrounds, and approaches to racial equity and the implications for the community, the research was more grounded and enriched by at the end, because you have the voice of the community there. By having representation of diverse organizations, persons, and in different capacities, also allow us to learn together, create this community of learning, where I feel like we went through a parallel process in which we were learning at the same time that we were discussing and providing input and information. So this process, to me, was key in the implementation of the project, because allow us to learn as we did it. And as I said, for me, I learned many things. I used some of the tools I learned in the job. So was a very rich process, and I think it was important for the whole research.
Thank you, Nubia. Appreciate that. And it was absolute a pleasure to be facilitating meetings with both of you in attendance. So with that, what was surprising information you learned from this repair research? What surprised you?
I would say the common challenges that we are facing wherever we are. So I'm coming from the perspective of, a healthcare system that is part of a referral network. And we saw these common challenges of truly deeply engaging the community, building trust, and then addressing and resolving the needs and the issues of the people coming to us. And there's a similarity, in fact, between the needs that the surveys identified in terms of the referral network organizations and the community itself. We're both looking for the same things. If you look at those answers, that's what really everybody is saying. They're responding to different questions, but at the end of the day, they're looking for the same thing. And that, to me, was actually very encouraging, that there is this alignment. And so I don't know if that counts as a surprise, but that was good news for me.
I can tell you what was not surprising for me is the relationship when you ask people what the networks offer or bring to you is that relationship building, which I think is the heart and soul of the networks, and we need to keep that going anyway. But going back to the question, what surprised me was the funding source for the networks. We have here that only it comes from government grants and only 2% comes from health systems. And I think the network needs to, grants are great, but that doesn't give any steady way of survive as an entity and in the community. And the other thing that surprised me, and this is just, is that the level of satisfaction with the services that was found in the Latinx community. And what the reason it surprised me is that from that compared with the comments and my own experience working with the Latinx community for many years, we know that there is a shortage of culturally relevant services. So I wonder, in my assumption is that maybe some other factors like let's say, internalized oppression and entitlement, and all of those things will have influenced the responses of the people. So maybe it's another research for you, Tris, is to examine this closely and understand how this affects not only the quality of the services that they receive and the satisfaction, but also affects how people can voice out these concerns and work to be better and affects their quality of life at the end. I think this is important conversation that needs to happen.
I love that, and I appreciate that. And I want to make a point of something Gary said, and then I want to go back to what you just said, Nubia. You know, Gary, you talked about the similarities, and again, we are talking to all of you from California to Rhode Island to Washington, Washington State and Virginia, and having all of these similarities, no matter what part of the country you are. Now, granted, we had a small sample size, 65 211 calls, 156 client contributors, surveys, 37 network partners, and then 7 P&Os throughout the country. So it was a small sample size. However, the themes were consistent regardless of geography. So that really allowed us to understand that we're still struggling. We're all struggling with some similar things. And so that was, I think, was really significant. And in addition to the point you were making. And Nubia, I tell you, when we were talking and validating this information in our meetings, and you brought up the idea of, is the satisfaction level so high because these communities have such a low bar of expectation? That rings so hard in my head. And I've been, for months since our conversation around that, been thinking about that, because we are so, as a community, and especially communities of color, conditioned to not expect the most, to not expect the best, to not expect consistent. And so if you're getting a little bit, then that's better than nothing. Yeah. But is that the level of expectation people should have in these services that we're working towards?
And Artris, I just want to ask this, to add this, is that networks have the potential to change that through meaningful conversations, difficult conversations, and to training and awareness and working together, have the potential to change that.
Exactly. Go ahead, Gary.
Great. Excellent point. And I do remember when Nubia made that point, it really hit home, I think, with many of us. And I think this is one of the areas where the networks can make a difference. because the networks can set the standard. The networks can continually raise the bar. The network can raise up organizations that might be falling short. And then the networks, and then this then gets to the question of sustainability. Because I think that also, while sustainability is needed for the network is also a key to sustainability, because I think these networks are essential to deliver results. And when they deliver results to large healthcare systems, and by that I mean everything from hospital systems to payers to government funders, et cetera, there is a demand on that end for these issues to be addressed, because their integral relationship to health and well-being and outcomes is now fully recognized. Our ability to sort of act and deliver on that is not yet there. But if a network can do that, then I think resources will follow. Remember, Artrice, at one point I said, people love to say, oh, well, this isn't rocket science. And my comment was like, you're right. This is actually harder. We've already put a man on the moon. We did that, 50 years ago? This is one we haven't solved yet. So this is tougher than rocket science.
Absolutely. Absolutely. Because when we think about, complicated problems and complex problems, complicated problems have an answer. It may, if your roof is leaking and it's complicated and I can't fix it, then we can hire somebody who has the skill set to do it. So it may take a little time, getting a couple bids, making it happen, boom. But if you have a complex problem, and you can use that same roof analogy of, okay, I have a hole in my roof, but I can't afford to get it fixed. And and my home is not settled. And so therefore I'm not performing well at work. I'm losing my job. So that becomes a complex problem that we need lots of different input and influence to make different and to change. And so again, putting a man on the moon, or a woman, or anybody on the moon at this stage, complicated, but solution, addressing community health and well-being, complex, many solutions needed. So with this information that we've gathered, how would you guys leverage the information that you're learning? And one other point before we go, I know, Nubia, you brought up the financial pieces of how this, I was a little surprised of how these networks are being funded. For everyone, in 2 weeks from now, on the 29th, we'll have an in-depth discussion specifically around the financial costs of these projects with our colleagues Hannah Duvier and Sean Yu, to talk about the financial research findings. So please stay tuned and come back for that. But with that point, this leverage of this information that we have, how would you both leverage it in your communities and be able to move it forward so that we are doing something that supports the communities we hope to serve?
Trace, I think the research demonstrates the importance of the relationship building and in the communities, and the potential to improve those systems occur by centering the needs of the community, understanding and keeping racial equity practices and cultural appropriate responses to services. This research, I think, underlines the need for accessible services. You just say the need to eliminate barriers, and having a pool of providers that it looks like the community they serve is important. But perhaps the biggest leverage is the synergy that the networks bring when talking about equity, racial equity issues, when talking about best practices and providing training to the people in the network, so they can have a ripple effect when they go out to provide services.
I would say is to make sure that people understand that the equity and the inclusion are just as important to success as your IT platform, as your finance systems, as your HR system, et cetera, et cetera. This is just as important. It is not off to the side and something else. It is the heart and soul of what this work is all about. And if we're going to be successful, it has to be at the center of what we're doing.
I love that, Gary, and especially when we're in an environment that every day you read the news that another, anti-DEI process is in place, whether it's government, whether it's school, whether it's state laws. And so it allows us, as we look at this project that spans the country, looking at what is happening in your community and in your backyard that you can see and help to address. If this is really pivotal in moving us forward, how do you address those environmental pieces that you may feel out of your control? But as a voter, you have control, you have a voice, and as a taxpayer, you have power.
Mhm.
So those are the things that we always have to kind of remember about our own privilege and power in the spaces that we navigate. Now, in our conversations during our meetings, you both had some really innovative, and thoughtful ideas regarding CRNs. For example, Nubia, you mentioned counties funding organizations to participate, so you want to expand on that idea and, and Gary, share any other ideas that you had?
Well, Therese, I think networks are supporting a system of services are so important for as a they catalyze these resources on all these things, and they bring this synergy, as I said before. So I think it has to be some really effort to fund in permanent way the networks. And I was thinking, why not 1% of whatever is used just to support the networks in such a way that they don't have to be running around just looking for a grant, put the effort on training, education, and providing the community the opportunity to understand how what they do can be better by embedding equity into everything that happens. So I think it will be an investment. It won't be a stretch or something that, no, it will be an investment and the results will show very soon.
Thank you, Nubia.
Right. I would say what is essential is for the energy and the leadership to come from the local community itself. Rather than, and I think that this is a real risk that we perhaps run, is with external entities coming in and perhaps with a very large price tag, promising a very simple solution. That is going to be very attractive and enticing to stressed healthcare systems who are looking to, how do we get this solved? How do we check the box? How do we move forward? So the real innovation and leadership, and I think the effective systems are going to come when they are locally developed, locally led, locally generated networks. And I think the key is to make the broaden awareness of who realizes the return of what is being delivered. I think one of the things, and I'm fortunately drawing a little bit of a blank on the details now, sort of basic infrastructure was often not accounted for in the cost of the network, and then often not charged. We need to be open and honest with ourselves about the cost of this work and the value of this work. And that's essential. And to make the broad array of folks realize you're realizing a return, you're realizing a return, you're realizing a return. We need to bring all of this money to the table.
I love that. Wonderful. And my last question for you guys before we open it up to the audience in terms of their questions and experiences. So we went through a process and we've been together for, this has been a 2-year project for Health Leads and the investors involved in this. and we've been with you all for a year in terms of the community advisory group. So is there something that you've gained from this process that maybe if you weren't part of the RePARE project, you would maybe not have come across it in this last year? Nubia, you're muted.
Okay, I say I can go. Personally, I learned a lot just for my work, for my personal growth in regard to equity and all these things. As I said before, I use it, and I am glad I was there. I was part of that. The other thing is, I came, but I didn't understand how these networks is an opportunity to be a participatory entity, produce provide opportunity for people to grow, create awareness, to just create a community that is more responsive to everyone. And I said that because when you have a network, you have everybody at the table and you can design programs and you can and systems that are more responsive. So that gives the opportunity to everyone to go and tap on the network and say, help me to design this new program. And then you don't come out with programs that have thousands of forms that people that don't have a lot of education cannot fill. So, and it's aimed for them, so on and so forth. So that's my, this is an opportunity and seize the opportunities, right?
So I would say a few things. One, I learned that you and Daniel are amazing rock star facilitators. And I'm going to miss you two. We have to find some reason to like hang out for another 18 months. What was great about this project is we all are very busy in our day-to-day lives. We're very focused on what we're doing, and it was great to sort of poke my head up and say, oh, I'm not alone. This is a challenge that someone else is facing. This is how they're addressing it, or they've had the same idea too, but they, what was the variation on it? Incredibly valuable for you to know that, what we're trying to do, we're all coming from the same place. We're facing many of the same challenges, and to have, a sort of team that you could be a part of was wonderful.
That was very sweet. Believe me, we were truly honored to be in spaces with all of you and working really hard toward the common good. And so honestly, deeply thank all of you, and both of you specifically for being part of this conversation today. And so we're going to keep you connected in terms of the conversation, and we're going to speak to some of the things that the audience in their registration brought up and some of the questions folks had and some of the answers to the questions they had. And so with that, I'm going to check in with our Health Leads team in terms of who's going to stay spotlighted. Are we bringing I'd like to bring Daniel and Christina back so that if there are questions, we as a collective will be responding. Perfect, thank you. And so one of the things as we delve into the questions and comments that have been made, I wanted to respond and give information regarding the questions that you all answered in your registration. We asked about your experiences of what do you think is not working with CRNs in your community. And so the themes that came back in that in your registration responses audience was organizational and systemic barriers. Efforts were needed to shift organization cultures towards being community-led, including overcoming resistance to power sharing. These are the things that you all shared with us. Isolation and disconnection. There's a tendency for organizations to operate in silos and without adequate connection to the broader community. Technical and operational challenges. Interoperability difficulties in achieving seamless integration among different databases and IT systems. Staffing and resource allocation. The lack of personal dedication to tracking and managing referrals and challenges with onboarding CBOs to adopt new workflows. Financial and resource limitations. Sustainable funding, the continuous struggle for securing sustainable funding and financial support. Engagement and participation. Overcoming the lack of community representation and ensuring that CRNs are truly reflect and meet community needs. And then set strategies to increase the adoption and the use of CRNs by community-based organizations. Communication and coordination, addressing barriers to effective data sharing among the network partners, and enhancing communication and cooperation among healthcare systems. So that's what when we asked you all what is not working in with your community referral network, these are the things that you all brought up. So we'd love to engage in conversation, answer questions that you may have, but also just get some voiceover in terms of a community conversation around community referral networks.
So,
Gary.
Artrice, I'll tell one of the advantages that I've seen from the network is you only know what you know, and you only know who you've worked with. You only know how you've ever solved anything before. And a network is going to expand your scope of organizations, people, strategies, and options. And that is going to help you do a better job. And if a really good network is going to make everybody stronger by bringing more resources to them, so that if someone who's there like, well, oh, someone who comes in with this need, oh, I always send them to this place. Great. That's not the only place. And what about someone who walks through the door with a need you've never dealt with, you've never seen before? You may not know where to turn. The network can step in and help with that. The network can step in because if multiple people say, I've got people coming in with this need and I don't know anywhere to turn to, well, the network can be the source of saying, okay, how are we as a community going to create a response to this new emergent need?
Thank you, Gary. I am getting a question that just came in. Could you speak about the ways to recruit support economically and logistically and maintain community participation in health system meetings, and best way to do that across language differences? So, Gary and Nubia, in terms of your experiences, are you able to do that? Are you able to see that? Again, can you talking about recruiting support both financially and logistically in terms of the network that you work within?
Well, one of the things I think the networks do very well is to create these connections around, and that they can have the people in the network become ambassadors for them, telling the story of how they are growing because the network, how they are learning, but also bringing the voice of the community there and helping them to understand the needs of the community. That's one way to do it. But the other piece is when you have different organizations with different needs, you have more people looking for resources, and you can bring all this knowledge about resources to the table and decide how to go about funding. Saying that, I want to say something. It will be even better if they don't have to do that. Even better if they just concentrate on supporting the community and the new design and breaking down the structure that don't work and so on and so forth. So I would say that know your government role, know where you can come in, what is the door you can knock, and also your funders and your health providers, because all this, what we are talking about here, is to support the well-being of the population, and that is I think it's an asset for everyone.
Nubia makes excellent points. Yes, know your community. The resources are there. I mean, we spend more per capita on healthcare than any other nation of our ilk in the world, and yet we get worse results than absolutely everybody else. We're putting resources into the wrong place. The work we're talking about is putting resources where there will be real, meaningful return. So the resources are there. They're just going into the wrong places. They're going into emergency rooms. They're going into emergency services when we should be and can be investing elsewhere. And there are major players in every community that recognize this inefficiency, and they have the ability to turn the ship, get their attention, bring them on board. Perhaps it's the United Way, perhaps it's Medicaid, perhaps it's large payers, perhaps it's large hospital systems. Find those allies and bring them together, because they recognize the inefficiency, and the market and government and regulators are forcing them to think more in this direction.
Thanks, Gary. What's interesting, one of the comments that was put in the chat was moving from a system, not silos mentality. That shift to collaboration and not competition requires knowledge of how technology can connect us regardless of platform. There is a lack of resources, time, and trust. Would you start small with key partners and build from there, or aim to think broader, involving multiple sectors that are sometimes resistant, still figuring it out, and aren't taking community-informed approach? So I guess the question is, do you start big and aim in, or do you start small and hope for spread?
I think you always have to think big. You always need to think big and think ambitiously. But I do think you can be more effective and get to some results faster if you start a little bit smaller. I'm not going to say start small, because I don't think you actually can start small. I think you need to have enough of an impact that people are going to notice. You need to have enough of a coalition, enough of a network, enough patients' lives that you are touching, that it's going to be noticeable. But yes, start with a coalition of the willing, as it were, and work from there, demonstrate the success, but always be talking about the fact that ultimately this is about something much bigger than whatever we are doing today.
Just to add something, is be an influencer as a network, and also align with influencers in your community, which could be many types, but that is so important, so you can start paving your way to where you want to go.
And that's to your points, to both of your points earlier about know your community, know who are the people who have the ear, and it may not be holding, political positions, or may not be holding, titled positions, but are community leaders who really are the voice of a part of your community and population, to really get them involved and ask them, how do we get started? What makes sense? Because I think the more people involved in the conversation and design, the more inclusive it will be. In another part of our work, we talk about, my colleague would say, back in the day, if you build it, they will come. But we're seeing that that's not the case. You can build it and they don't come. But if they build it with you, they're already there. So they don't need to come. And so that is how, you can start really engaging and expanding this work. When we think about the answers to the other question, could we ask, what is working in this community, in your communities? What is you know, what's the positive? Give me 1 second, I'm going to grab that information. So it's very easy to end on, you know, what's not working, how, and so we asked what is working in terms of CRNs in your community? And this is what the audience had said. Relationships and collaboration, both on a small group level and across the organization. You know, the relationships are pivotal to seamless collaboration and resource sharing. Organization, collaboration, and partnership. Collective efforts of various organizations, including the CBOs, healthcare, and technology platforms. Growth and development and shared knowledge and experience and expertise. The roles of community health workers, CHWs, they're integral in this work. And health information networks and data sharing, being able to share information and doing it in a way that respects privacy, but also allows your community members not to tell their traumatic story over and over again. Because there's nothing worse than going through something tragic than having to explain it to 5 people in a row, and you're asking, why can't you guys talk about these things so I only have to tell one person? So really making those things come together is what's working in community. So what are you guys are finding what's working, you know, when you're really thinking about coming into work every day and engaging this process, like, wow, we need to keep this up because this is really working.
And you're asking us,
Yeah, I ask you, but I would love for even the audience to respond in chat or, you know,
yes,
engage.
I would love that, but I would say, but it's working. It's surprising for me when you have in a same place, via Zoom or in person, all these agencies that come together that usually they will be competing for funding, but now they are here together talking about whatever issue is the issue of the day, but they are have the opportunity to explore new things, new ways to do things. That is working for me. And not only that, but as Gary said before, you have a person that came with a need that you didn't have before. You can just take the phone and call one of them because now you know them and you know what they do and how they do it. So that is works and that relationship works.
Excellent points. I would say another key is realizing the many different stakeholders who have an interest in the outcomes. And I'll just pick one really small example. We may have, as part of our accountable entity, a kid who's making multiple trips to the emergency room for asthma. Okay, that is inefficient. It is traumatic. We want to correct that, and we want better health outcomes. Well, tied to that is access to medication, understanding and education about maintenance meds and emergency meds, but going deeper than that, what is causing this in the home? We may have mold, we may have rodent feces, other environmental risks. We need to address all of those. We can then make the child healthier. We can make the primary care practice happier by getting better outcomes. We're also going to, chances are, improve that kid's school attendance. Because in Providence, one of the leading causes of chronic absenteeism is asthma. And so by dealing with this issue of, oh, this kid's going to the emergency room too many times, that maybe is the thing that makes the little alarm bell go off on my computer, but it speaks to deeper issues. And if I can then say, my solution is going to benefit all of these folks, let's bring people together to really look comprehensively at this issue. So now we're involving the school nurse in the education as well. Well, now we're really delivering for that kid and we're really delivering for the community.
Wonderful. And so last question I have for all 4 panelists, Christina, Daniel included, from this project, what's the biggest takeaway you're going to take away from the RePARE project experience and information?
I love that question. So I think there's a couple of things and takeaways. But I do think in part of this learning, and it constantly comes out throughout, kind of my trajectory of being a nonprofit and doing community work, that there continues to be an underinvestment in community partnership. And I want us to make a distinction between partnership and engagement, right? The way I think of engagement is kind of a series of one-offs. And I'm not saying that they're not important, because they are. But I want us to kind of move towards, community partnership. And I think that talks about shared power, that talks about shared decision-making, that talks about sharing information back and forth. And the beauty of a roundtable of diverse perspectives, I think it's so needed for us to move the needle and transform equitable systems. It's this thing where not one of us holds the knowledge of how to do that, right? Community members are going to come in with a perspective that healthcare doesn't have. We know that nonprofits have proximity, and community-based organizations have proximity and relationships to community, right? And is there an opportunity for healthcare and CBOs to kind of leverage each other's expertise to help build that? And so I do think that I'm excited for the opportunities here, kind of moving forward. I'm excited to be having these conversations. And the other kind of second point is, I know oftentimes we focus so much on the importance of outcomes. And I think the outcomes are important. Obviously, we want better community health for BIPOC folks and all folks. However, I also think through this process that, if you don't have equity in your process, how do we expect to have equitable outcomes? Right. So I think it's as important for us to look at equity in our processes and not just pick and choose where equity lies, but really question and reflect, how can we improve equity in our processes?
One of the takeaways for me is how the potential for networks to dismantle these power dynamics that are perpetuating inequities. So that potential that is there, that we need to leverage from that gathering of people and ideas and all these things to really break that cycle of inequities, because the system is designed by and for and all these things and so on and so forth. So that's my biggest takeaway, is that has that potential, has that synergy that we need to keep moving forward and breaking those, because one person alone won't be able to make it, even if you have the most conviction or whatever. It's just we need all of us there working on that.
Yeah, I wholeheartedly agree. I think one person alone can't do it, and one entity alone can't do it. Right here at Health Leads, this project wouldn't have been possible without you, without Gary, without the PNOs and CHE. So it really is, going back to what Christina was saying, building alongside community members. None of this research would have been possible without our community advisory group there to support at pretty much every step of the way. They were the folks who organized the listening sessions. They were the folks who outreached for all of the surveys that we received to inform us on everything that we shared today. So from that experience and from what we shared earlier with what PNOs are saying is needed and network partners are needing, I think co-design with community is really the biggest takeaway from this project for me.
Any last thoughts, Gary?
No final thoughts. I just want to thank you and Daniel and the whole Health Leads team and all of the other folks in this project. It's been a wonderful experience, learned a lot. And also thank you to all the folks who zoomed in today. I don't know what the right verb is. I guess they zoomed in.
Thank you. And perfect segue to thanking all of you for being part of this conversation. It's part 1 of 2. So please come back February 29th 1 p.m. Eastern, 10 a.m. Pacific, for the developing community. We have, as it pops up on the screen right now, the poll. Please take a moment and fill out the poll. And I also truly want to remind you all that this recording and resource links will be sent to you all, but also posted online on our website. And a copy of the full report will be sent out via email, and again, posted on our website in the next 2 weeks. But I also truly want to thank Common Spirit, Blue Shield of California, the California Healthcare Foundation. Without their support, this project would not exist. And also want to make sure I thank all of the members of the Community Advisory Group and our participating network organizations, Sonoma Connect, Sononos Unidos, Bay Aging, Chicano por la Causa, United Way of Rhode Island, United Way of Mohawk Valley, United Way of San Joaquin County, and People for People in Washington. Thank you all. Have a wonderful, wonderful rest of your day and wonderful weekend.